Hello, good morning, good afternoon, and good evening to all our speakers, chairs, and the wonderful audiences in different parts of the world. Welcome to ACNS webinars. The speaker for the first session of today is our honorable guest from Germany, Dr. Felix Gore. Dr. Gore is a consultant neurosurgeon and head of neurovascular services at the Bergmannstorf Hospital, Halle, Germany. He did his fellowship with Prof. Juha Harnesniemi in 2012-13 and was also appointed as an adjunct professor in Helsinki in 2018. He reserves his expertise in the management of complex cerebrovascular diseases like aneurysms and AVMs. We are extremely honored to have him today as a speaker at our webinars, and today he is going to talk about microneurosurgery, neurovascular applications. The speaker for the second session of today is our honorable guest from China, Professor Sun Ye. Professor Sun is a chief physician, associate professor, and master supervisor at the Beijing Jiantan Hospital, Capital Medical University, Beijing, China. He is a vastly experienced neurosurgeon with over 20 years of clinical practice specializing in cerebrovascular surgery like complex intracranial aneurysms, conducting extracranial intracranial bypass surgeries, and management of AVMs. He is also a proficient in the surgical management for Moyamoya disease, and he has been actively engaged in academical and clinical research member in several prestigious academic organizations. We are extremely honored and grateful to him for accepting our invitation to be a speaker at our webinars, and today he will be talking about bypass application in aneurysm surgery. The chair for the first session of today is our honorable faculty from Japan, Professor Nakao Ota. Dr. Ota is a Vice Director in Sapporo Teishinkai Hospital Stroke Center, Department of Neurosurgery, Hokkaido, Japan. His research interests are focused mainly on cerebrovascular surgery, and is an invited faculty to various workshops and conferences conducted worldwide. He has published several articles in various peer-reviewed international journals, and we are extremely honored and grateful to him for accepting our invitation to chair the session of Dr. Felix Gore. The chair for the second session of today is our distinguished faculty from Chile, Professor Jorge Mura. Prof. Mura is the chairman of the neurosurgery at the University of Chile, Asenjo. He is also the president of the Chile Neurosurgical Society, and he is a towering figure in the world of cerebrovascular surgery and proponent of his novel technique of MIPLATA procedure. We are extremely grateful to him for accepting our invitation to chair the session of Professor Sun Ye. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, I would like to welcome both the speakers, chairs, and these wonderful audiences to this online platform of ACNS webinars. A very warm welcome to our colleagues in China, and we are extremely grateful to Professor Shubin for broadcasting this webinar on the WeChat channel. Dr. Libun Singh from Malaysia is my co-host for today, and with that introduction, I would like to hand over this online podium to our first chair, Professor Nakaota.
Welcome to everyone joining us today. I'm Nakaota of the Sapporo Teishinkai Hospital, Japan. And we are pleased to have participants from many time zones with us. I'll show you a brief introduction. Today, our focus is on microneurosurgical techniques for neurovascular conditions, a field that has evolved rapidly alongside endovascular treatments. The standards for open surgery have become even more demanding, and these refined techniques now allow us to tackle some of the most complex vascular regions with precision and care. In this session, we have explored the latest developments in these techniques, discuss some of the key challenges we face, such as minimizing ischemic damage and ensuring safe revascularization, and learn from pioneering approaches that continue to push the boundaries of what's possible in neurovascular surgery. The goal today is not only to share expertise, but also to foster collaboration across our field, as neurovascular surgery is one of the constant learning, improvement, and interdisciplinary effort. And I'd also like to add a personal note. Today's speaker, Professor Felix Gore, is a longtime friend and esteemed colleague who has made a significant contribution to microneurosurgery. During this 2015 to 16, we have some collaboration with him. This is Felix published 2016. This is the P2 double aneurysm, which treated by the STA P2P bypass. And this is another case. That time, Felix had many interest in the posterior cerebral arteries, and he helped me to write this paper. This case series is very good for the revascularization for many regions of the posterior cerebral artery. This is a case with giant thrombus aneurysm, which treated by the occipital artery, calcarean artery bypass with proximal occlusion, which successfully treated. And this is Felix published in 2016, and this is microsurgical embolectomy of the basilar top embolism. And nowadays, mechanical thrombectomy is very developed, but however, some case needs a surgical thrombectomy, such as difficult to access or contrast allergy, or patient something didn't perform angiogram. This is a very good technique for the surgical embolectomy. So please, Felix, please start your lecture.
Thank you very much for your invitation to the ACNS family. A few months back, I had already one lecture on microneurosurgical applications. And my idea this time was to continue where we stopped the last time. First, I would like to show my working place in Germany. This is our hospital in Halle, Saxony-Anhalt. And it's 100 years old hospital focusing on trauma and stroke treatments. And we are doing also complex vascular cases. And for today, first, I would like to say something about focused opening of the Sylvian fissure. And the second is maybe also as introduction to the second lecture, I would like to say something about extra intracranial bypass procedures and their application to the posterior circulation. And at the end, I would like to continue with upper posterior circulation aneurysms. And so, focused opening of the Sylvian fissure. This is mainly based on my experience from Helsinki when I was working together with Juha Hernesniemi, and the experience with the MCA aneurysm and the focused opening is published by Ahmed El-Sharkawi. The second publication we see here is from Kasumata on the Sylvian veins, and both together helps a lot to perform such surgical procedures. First of all, we do need the LSO approach. For this, not so many instruments are required. I like to use the Sugita frame in counterbalanced microscope with mouse switch. And I like to stand to have a perfect angle to look into the Sylvian fissure. And in background, we can see our OR here, same. Head positioning and table position of the patient. To perform the LSO, we split the temporal muscle a little bit in the upper frontal aspect and detach the muscle from the skull. While planning, we can look on bony landmarks where we later are going to open the Sylvian fissure to find the aneurysm in the small corridor. And I think later we can discuss this also with Dr. Ota, because the Sapporo concept is a little bit different. Here, the skin incision and soft tissue management, trepanation, craniotomy, and then dura opening. And to exemplary case, this is an unruptured left MCA aneurysm. We operate in a live demonstration course in Wrocław. And here the aneurysm affecting the left MCA bifurcation, M1 is quite short. And now we are opening the Sylvian fissure above the aneurysm formation. Here we can take a first look into the Sylvian fissure. Here, one M2 branch falling to the bifurcation, then changing the angle a little bit. And here we find the aneurysm. Using this strategy, it's possible to place the clip around the aneurysm neck, and then we can inspect the situation a little bit more. Here we see a small remnant, what we can occlude with a second small clip. Overall, we can see around the aneurysm, also with the ICG check of the aneurysm closure, and at the end, the aneurysm is completely occluded. Second topic, extra intracranial bypasses. And this is a nice drawing from Peter Roth, Zurich, what I saw in the conference, and I was able to buy one of the drawings. Here we see an sta-mca bypass and one high flow bypass with the interposition graft. I was trained in Zurich from 2009 to 13 with Rosemarie Frick, and she is one of my most important teachers. Fortunately, below the cerebrum, we have the circle of Hülles, which is able to perfuse the brain also when we have major vessel occlusions, but we have a variation. And here in this graphic, we can see that in all of our brains, we have a different configuration of the circle of Hülles. And by this, we need an individual strategy for each case we are going to treat. And next page is the donor vessels, or the most common donor vessels, the sta branches and the occipital artery. Here in this publication from Kawashima, we can see the diameters of the vessels, and one are the recipients, and here we can see the donor vessels. So occipital artery is around 2 millimeters and sta also around 2 millimeters in size, what is similar to the M2 branches or the PCA trunk. So sta-mca standard bypass publication from Nadia Khan, localization. This is the typical entry point for standard bypass around 6 centimeters above the tragus. And here we can see the dominant branch, what we used in that case to perform the anastomosis. Here one example of the basic suturing technique. And I think this is the basis of all bypass procedures. Maybe little mistake from my side. I think when cutting the suture, it is important to see the node, not to cut it too short. ACG perfusion when bypass or standard bypass is running. And high flow procedures, we can take the radial artery, or also we can take the venous vein graft as standard interposition grafts. We need a neck opening. In Halle, we do it with a longitudinal incision, but the flap, the cranial flap, I think is something like a standard worldwide. dissecting the Sylvian fissure to find the MCA as recipient, and then the anastomosis in the Sylvian fissure. This is an own case with a radial artery interposition graft. And here is one case. What we have done in February was a young female patient with a ruptured ICA aneurysm. In other hospitals, they were able to clip the aneurysm to stop the bleeding, was also ruptured intraoperatively, and they had to occlude the ICA. And the result was we had a perfusion deficit on the left hemisphere, and we transferred the patient to our hospital, and we did this bypass procedure to perfuse the whole left hemisphere, and the patient was able to recover very well during the last 6 months, now living independently. And in 2011 in Helsinki, I had the possibility also to see bypasses to the posterior circulation, in that case an sta PCA bypass, and I start training these deep procedures in Zurich later with this setup, and I could read the literature mainly from Professor Yonekawa and Ralf Sund. I took instruments for deep corridors, and then I could start to do such procedures also in Halle. This I want to show you the 3, from my point of view, standard procedures for the posterior circulation. One is the occipital artery to BICA bypass, publication already a little bit older, from 78 from Thoralf Sund. Here we can see the technique of harvesting the occipital artery, and then the approach to place the bypass to the loop of the pica, and sorry. So, and this is one case. The patient had ongoing stroke in the posterior circulation, and this patient we treat with this standard occipital to pica bypass to perfuse the posterior or vertebrobasilar circulation. Another case, this patient has a fusiform vertebra pica bypass aneurysm at the origin of the pica. So we see the pica coming from the dome of the aneurysm, and what we decide to do is an anastomosis in between both picas and to trap the aneurysm. This is an illustration from Spätzler, and this is a result of our surgery. And here we can see how the bypass or the side-to-side anastomosis is working. So this was an open pica and gives perfusion to the distal or affected pica, and slowly also to the perforators in the proximal segment, and also the medulla is very well perfused. Aneurysm in this situation is already clipped there. Then we have sta to SCA or PCA procedures, what we also can consider as standard procedures. This illustration from Yonekawa shows that using the standard subtemporal approach, it's more easy to look straight to the SCA when we are going, or we have to see the PCA. For the standard bypass procedure, we have to retract the uncus a little bit more and to have enough space for SCA procedures. Also, I like to split the tentorium a little bit. Looks like this. And here we have one case. Patient had a coiled basilar tip aneurysm, and somehow the patient developed in vertebral occlusion on the left side and had a severe stenosis in this area on the right side. And we decide to apply additional perfusion to the upper posterior circulation using this sta to SCA bypass. And using this technique, it was possible to stop the small strokes the patient developed by the vertebral-basilar insufficiency. So some relevant literature. I think when we're going to Google Sund Ausmann, we find most of the literature, what is needed to do this, and this atlas is also very nice to read. Now we are going to see upper posterior circulation aneurysm. Statement of one of my seniors in 2008 was, there's no need to operate on basilar bifurcation aneurysm because we have endovascular treatment. And here we see a large aneurysm affecting the brainstem, also by its aneurysm mass and pulsation. And we are going to clip this aneurysm also to reduce the mass effect and the pulsation. And I was able to work with Stuart Hernesnemi for a while, and together with Peerless and Drake, they published the experience from London, Ontario, in this 1,767 patients. And it's a huge experience. And this also reminds us Juha, who died last year. And as I know, this is one of his best moments in life. He was able to clip a basilar tip aneurysm, not this aneurysm. And Professor Yashagir was watching the surgery. And 2016, I had the chance to work in Sapporo for a while. Also, here we were working on posterior circulation aneurysms. Rotterdam course on aneurysms, also focusing a little bit on posterior circulation aneurysms. And here we see a nice image from Paraga, which also show us the difficulty with those aneurysms. So we have the midbrain perforators coming from the basilar bifurcation from the P1 segment. And when we have an aneurysm formation in this area, the perforating branches are extremely close and we have to take care for them. This is also an illustration from Arno Bennett. And here we see the structures we don't see from intradural, but I think Professor Mura likes this illustration a lot. And here is the course of the PCA around the midbrain. This also illustrates that we need different approaches to reach the segments. So we need an anterior approach to reach the proximal part. The P2 segments are very nice approachable from subtemporal or posterior interhemispheric, or also supracerebellar approaches for the posterior segments of the PCA. Here, one case, we see an SAH from a ruptured basilar bifurcation aneurysm, and we did this LSO approach. According to Professor Yonekawa, it is possible to reach this area when the aneurysm is a little bit above the posterior clinoid in one line with the floor of the anterior fossa, and we have enough distance in between the midline and the ICA course. Aneurysm was clipped like this. And now I'm going to show you one of those approaches with an unruptured basilar bifurcation aneurysm. Aneurysm formation. First, we need some space to elevate the frontal lobe. So we open the arachnoid layers above the optic nerve. Mobilize the frontal lobe. If we need more space, we have to open also the proximal part of the Sylvian fissure. But in that case, it was enough. So we can go through this window to the basilar bifurcation. From anatomical and practical point of view, basilar bifurcation is around 2 centimeters behind the carotid. Here we see small perforating branches coming from the posterior communicating artery, and we can see scissors are not very sharp anymore, but at the end, arachnoid layers are open. To do this, it is important to give some tension to the arachnoid layers, to have them a little bit under tension when cutting them. Now exploring the neck, here we see the P1 perforators behind the brainstem. We see small calcification next to the aneurysm neck, P1 segment. Now taking a look to the other side, other P1 below here. And now placing a clip around the aneurysm neck. Closing the clip by also checking the perforators. On the right side, we have one perforator also attached to the aneurysm dome, but there was no need to detach this perforator because we had here a small window to insert the clip plate. Now Doppler and ICG check. Everything fine. Perforators filling. Using this approach, we can clip in addition other aneurysms affecting the anterior circulation, like in this case. Now we take a look on the subtemporal approach. I'm going to explain this with an PCA aneurysm. So to have this angle open is necessary to give you enough working space. It's important from my point of view to place a lumbar train to retract the temporal lobe. And then with this skin incision, we can reach the floor of the middle fossa. Going back, of course, it's possible to open air cells here. So you have to check them carefully. And if you open them, then you have to close them carefully. This we have already seen, but this is the same strategy to reach the vessels. Here we see quite often the third nerve as first. And when we have the third nerve, we have orientation because then we also know the SCA is always below and the PCA above. And then we can follow these vessels also to find aneurysms more distal. In that case, it's an unruptured PCA aneurysm with this little bit difficult course of the PCA before the aneurysm. By this was not possible to treat the patient by endovascular means, and the patient was transferred to our hospital. Here we are opening slowly the ambient cistern. Third nerve, no, the fourth nerve. This is a course of the PCA. First, we see part of the aneurysm here. I placed one clip from this side. Now retracting the temporal lobe a little bit more, placing a second clip here, and then I could take a look around the aneurysm. And then I changed these clips, removed this, and placed another curved clip around the PCA from below, like this. And then the neck of the aneurysm is occluded next to the parent vessel. And at the end, it looks like this. Here we have calcifications. No aneurysm is calcification. And the aneurysm was completely occluded. Now, pteryneal anterior temporal approach. This is an ICA aneurysm in combination with an PCA aneurysm. Those images are from DSA, so this is why we don't see both in one image. And now, going back, so this is the P1 aneurysm, and now we're looking on the same aneurysm here. Again, the third nerve, SCA below, PCA above. On the left side, now dissecting the aneurysm. And here, again, we see the perforators. Those perforators coming from the PCOM. Clip the aneurysm like this. PCA open, perforators not disturbed. And now I'm going to show you in case where we can see nearly all of the aneurysms what we have seen before. So here, basilar, PCA aneurysm, basilar SCA aneurysm here. Now looking on the ICA, we have a small anterior choroidal aneurysm here and medial wall ICA aneurysm here. And step by step, we are going to dissect them. Anterior clinoid ICA, third nerve, opening the dura. Here we can see the PCA aneurysm, PCOM, aneurysm sac, SCA, and to see the PCA distal from the aneurysm, I had to remove a little bit of uncus here, and now it's possible to clip the main sac of the aneurysm. One of the perforators is here. Now the course of the PCA goes like this, but a part of the aneurysm is left. We are going to see this later. Second is the basilar SCA aneurysm. Put a second clip. This is the medial wall aneurysm of the ICA. As we have seen, opening a little window here to place it as a clip into this window, temporary occlusion, and now closing the aneurysm slowly, taking care for the perforators coming from the PCOM. PCOM goes like this, and the perforators from the proximal portion of the PCOM going here. Now removing the temporary clip. And now we have two things left. One is the small anterior choroidal artery aneurysm with intraoperative. I could see it has an extremely thin wall, and I put one of the smallest clip, but here I could already see that the anterior choroidal is affected here. So I had to change this clip a little bit to open the anterior choroidal, but at the end, so aneurysm is clipped. And now we have this part of the PCA aneurysm left. So we have the entrance of the PCOM to the PCA here, and the second belly of the aneurysm was here. And now we have the PCA in between both clips open, and all vessels are open and the aneurysms occluded. So Professor Tanaka said, so regarding the treatment of cerebrovascular disorders, the role of craniotomies is expected to reduce further, with endovascular procedures becoming mainstream. But I think what is going to happen is that the cases are becoming a little bit more complex, but at the end, we need a combination of direct treatment, what we have seen in the last part of the lecture, and also in those cases we need bypass procedures to the posterior circulation to resolve such problems. For example, small aneurysm of the SCA is behind this flow diverter, so it's nearly impossible to approach this with endovascular means. This part of the aneurysm is still filling through the wall of this flow diverter, and direct clipping is impossible because of the stent materials in the aneurysm neck. So this is the last page. I think I let this open to discuss a little bit the lecture. Thank you very much.
Thank you, Professor Boyer. We have some questions from the audience. First question, how you decide whether to do slow or high flow bypass needed in particular case?
I think distal from the M2 segment, STA bypasses are usually enough, but if you have to perfuse a whole territory of the cerebrum, then we need more flow capacity. So it depends a little bit if we need flow augmentation or if we have to replace the flow of the major vessels like the ICA.
Yeah, I agree with you. Yeah.
And otherwise, there's also a nice publication from Merkava where you can make calculations, but I think this is what I said. You can widely.
And we have another questions. For the basilar tip aneurysm, what is the criteria for you to do from left or right side? Left or right side?
Yeah. So when the aneurysm is in the midline, and we have, let me say, the other aspects also similar on both sides, then I usually like to come from the less dominant side. And in case we have specific configuration from the aneurysm form, from sometimes the angle of the basilar and also PCA and SCA are changing a little bit, then I'm going to respect those and change the best angle to approach the aneurysm.
Do you think LSO approach is enough to treat almost all basilar aneurysm, or you need some extended approach for the particular case?
In some aneurysms, it is enough. So especially what I showed to you, so you have no extremely wide neck aneurysm, you have the same line following the floor of the anterior fossa above the posterior clinates, then you can apply this. But in other cases, you need different approaches, or anterior temporal. Sometimes you need also a little bit space, and you have to open the cavernous sinus, and some aneurysms going in posterior directions, then you need in subtemporal approach, or even combined approaches are sometimes needed, but depends from case to case. I can remember, for example, one case, aneurysm was very big. I think I showed the case, and in that case, it was needed also to separate the PCOM, so that some perforators coming from the at the end from the ICA and some from the posterior circulation, and then I could view through this window, but I had a different angle from the clip, so I put the clip from this optical carotid window and was looking for the perforators from the lateral side. So sometimes this is needed.
Thank you. Do you have another comment or questions?
It's very important, some points that he said, that the microsurgery is not dead. I start in microsurgery in the beginning of the century, in 1999. And in that time, in 2002, the ISAT came, and the endovascular people said that the microsurgery was dead, ended. Okay. Now 22 years passed, and the microsurgery is still alive. For me, the endovascular treatment is a neurosurgery field. I encourage my fellows to do endovascular if they want, but never leave the microsurgery on the side. It's very important to keep saying that we need microsurgery because some aneurysms are impossible for endovascular, or the microsurgery is better. Why open the head must be something very terrible? You know, I said to my patients, if you have a problem in the heart, you never believe that open the chest make something with your heart. It's the same with the brain. Why you need to have something in your brain if you open the head? The head is the outside, is the cover. Okay, and if you do a proper microsurgery and you follow the anatomical principles and use microsurgery like Felix showed today, it's not a problem to open the head. It's safe. Okay, and endovascular and microsurgery need to be together, not against. And we published with Dr. Evandro. I trained with Dr. Evandro in 2000, I think, 2002 or 2004. We made a comment of a regrowth of a coil aneurysm, and we comment that probably in the future we have a new chapter, the microsurgery to treat endovascular failures, and the chapter is here. Felix show these flow diverters and coils, and sometimes we need to operate. We need to work together. The microsurgery is not dead. And my final comment is you have an alternative to you can treat this basilar, middle basilar, even proximal basilar and distal basilar aneurysm for the MiPlata approach. The MiPlata approach, you can go from the BV junction to the basilar tip, because it's a combination of all the philosophies, you know, the transsylvian, the pretemporal, the terional, and the transcavernous in a simple way. And then you made a tailored approach and you can see everything. Now we are operating bilateral lesions and other things and putting the endoscopy. That's I want to finish with that. The endoscopy can be used with microsurgery too. I saw a lot of people trying to put endoscopy against microsurgery. No, you can, are tools. I use both. I operate in a tumor and I finish with endoscopy, but I use microsurgery. What I'm trying to tell you now, and for the young guys, mainly is microsurgery is about study, like Felix showed. It's about history, follow the masters. He have a master in microsurgery, in the laboratory, in anatomy, you know, and finish is the practice. Nobody here is a genius that can is a natural, you know, no training needed. That's a lie. You need to train. You need to keep going, and you need to keep communicating this with between us. That's why these webinars are so important. This is not show off. This is share. It's different. It's different show off to share. We are sharing here, saying that microsurgery is alive. We need to keep going. And Felix, I know him for, I told you, more than time that I want, because I'm old, but we are old, but you are younger. And it's very important to the young guys to see this is not a rocket science, you know. This is something that you can get, and we must keep going. Thank you.
Thank you very much. Yes, Ben Sensei.
Yeah, I think I probably has a question that probably answer partly by Professor Muller. My question is about, I would like to ask about Professor Felix for your opinion, like for the young neurosurgeon who are still have the heart for the open cerebrovascular surgery. So in how do they pursue themselves in the as a open neurovascular surgeons in the endovascular era? I think this is quite hard, especially from the young neurosurgeon master technique. So very often, like we are faced with the most difficult aneurysms, like those recurrent aneurysm after the endovascular treatment, and those are really difficult to manage. And some of them, like we could not deal with them, and we due to the inherent risk, and then finally this patient finally left for a conservative treatment. And then another thing is about they could not eliminate the mass effect of those big aneurysms. So because we are left with those aneurysms, I think difficulty lies in, first of all, like the first is the periods and the vascular treatment. So you have coil and stent inside the artery. The second is the walls of the aneurysm are much more difficult to manage because they are thick, calcified, and have thrombus inside. And the third thing is about the potential of flow limitations that if you really want to deal with the aneurysm. So this making those difficult aneurysm very hard to manage, especially like we don't have much experience about the vascular reconstruction and keeping in an open approach. So how would you advise the young neurosurgeon to pursue themselves?
I think first at all, it is extremely nice to study the old books and the literature what we have, because this everyone can do alone at home. Second is you can see videos. I think nowadays it is possible to see the old webinars in YouTube. You can send also emails to colleagues you know who already did similar cases. For example, this is also what I'm doing. So I ask my friends, I send images, show some pictures, and then maybe I find someone who did the same already before, and then I'm watching their videos. But first, of course, you need own practice. You need also confidence from your endovascular colleagues. Otherwise, they don't show you the cases. And then, I think you need the combination of techniques. So what we have seen is this was also the idea of the lecture, to show vascular reconstruction, to see direct surgeries. I think this combination in future is needed. Also, combination with hybrid techniques together with the endovascular colleagues. I think not today many things are possible. I think looking 20 years back, it was impossible to send, for example, an email to Georges. Can you show me a video? And then maybe 10 minutes later, video arrived, and I can see how he did the similar situation. I think when I got the invitation for today's lecture, I already had an idea for maybe the next time we can talk about also complications and intraoperative rupture and strategies. What in most, also my lecture today didn't show extremely intraoperative difficulties like ruptures. For example, this is what we can talk about next time. But I think, this is the idea. So literature, videos, own experience on different fields. Also, when you operate on tumors, some aneurysms are similar to tumors. And in case, what you said, when we have endovascular materials in the affected segment, then sometimes no other option than to trap the whole segment as close as possible to the lesion and to reperfuse the distal territory. So, but it depends. By this, everything becomes a little bit more complex, and we have to take a look on the cases in video.
Thank you very much, Felix. That was wonderful. To cutting short, the youngsters need more communication, collaboration, and perseverance to keep the skill of microneurosurgery alive. We can take one last question from Mohammed Biswas before we go to the second.
Thank you, Sensei. Just with your permission, I have only 2 questions. Excellent presentation. In sir presentation, sir has shown the superior vena cava graft passing above the zygomatic arch. So, is there any principle or difference passing the interposition graft below the zygoma or above the zygoma? This is
I
number
think
1 questions. And number 2
so.
question, sir.
Okay.
Sorry, sir. Sir, in subtemporal approach, if the vein of lab is very dominant and the temporal lobe retraction may cause any harm to the labe, so what is the principle in that case?
Usually what you see in this big and dominant labes, you can mobilize the labe also a little bit to the main entrance point. But of course, sometimes when you retract the temporal lobe a little bit more, you see the vein a little bit stretched and becoming thinner. But at least it should, so the vein should be open a little bit. You can check with Doppler ultrasound. And the other question with the graft above the zygoma, according what I was reading, also I know the Sapporo experience is different. They are going below. So we have not seen complications with this classic placement of the graft.
I mean, you prefer to below the graft because I have seen Tanikawa and Takizawa sir, they used to tunnel the graft below the zygoma.
Yes, but I think subcutaneous is also fine.
Okay. Thank you, sir. Thank you. Excellent presentation. Thanks.
Thank you, Vishwas. In short, if you go to the literature,
thank you, Raja sir.
That graft can be passed either preauricular or postauricular. Preauricular can be above zygoma or below zygoma, whichever. It depends on just individual choices. So we'll go back to our chair, Professor Nakaota. Liu, do you have any questions before that?
Yes, the short question, Professor. Yeah. You show us the supraorbital, lateral supraorbital for basilar top. So when do we use a COZ now, Professor? Thank you.
Never. Good answer.
Great, thank you very much.
But maybe one comment. So when the basilar bifurcation is extremely high, in my experience, it is needed to, or if I need to look upward in combination with the pretemporal approach, it is nice to remove a part of the zygoma or take the zygoma temporarily out to look above. But I have never used the classic OCO approach.
Thank you.
Yeah.
Thank you. So we'll go back to our Honorable Chair, Professor Nakaota, to hear his concluding remarks.
Yeah, thank you, Professor Felix, for your good presentation and nice videos. And we are very educated and impressed. So now we'll finish this session. Thank you very much.
Thank you very much. It was indeed a very interesting and educative session. Thank you very much, Dr. Felix, for being this part of the educational webinars. So now we'll move on to the second session. Our honorable speaker, Ye Sun, has joined us. Professor Sun Ye, can you hear us?
Thank you for everybody that's here with us in this session. We will discuss now a very interesting issue, that is the bypass surgery for aneurysms. Felix talked a little bit about this in the previous session, and I want to say that for a cerebrovascular surgeon who deal with aneurysms, the first thing is to be mastering clipping. That's the most important thing. You need to be first very good clipping, because 90%, 92% of the aneurysms you can resolve with the clipping, but you have to be able to do bypassing, and maybe in 8 to 10% of the cases, because in that case the bypass is better. Sometimes you have to treat endovascular failures and deal with the lesion with a stent, with coils, with calcification. It's too hard. But if you do a bypass, you can resolve the problem of the patient. And the other thing is we need to use the revascularization up to date, because we need to deal a lot with the stroke, with ischemia, cerebral ischemia. And then for me, the sta-mca bypass is part of a cerebrovascular surgeon that define a cerebrovascular surgeon. A cerebrovascular surgeon that just do clipping in aneurysms, have patients that he cannot treat properly, and he cannot deal with ischemia. And cerebral ischemia is very, very frequent. And then the issue of and the chapter of bypassing in aneurysms is very important, mainly for the younger neurosurgeons who in the future who need to deal a lot with cerebral ischemia, chronic, subacute, and acute, and with the more and more complex cases of aneurysm. Sometimes an sta-mca bypass is a very simple solution compared with trying to reconstruct impossible aneurysm with calcification, thrombosis, endovascular coils, stent, etc. And I welcome Professor Xun-Ye, who's going to talk about this very interesting issue. Thank you, Professor.
Sorry for inconvenience of Ye. He has a very he is on his travel to a very important work. So he may I'm come from Ye Xun's team, and I'm also a neurosurgeon. So he represent here to share his point here. So I'm here to share our experience of the strategy of the surgical treatment of aneurysm in the context of interventional preoperative. So in today, more and more aneurysm, maybe more than the 19% aneurysm were treated by endovascular treatment such as embolism or invascular revascularization, and surgery such as clip, ramp, Appln may be more and more less. So how we survive in this period and this duration condition. So such as the first case in our institution, the first case is an emergency rupture of the sta-mca artery aneurysm. So we can use the stent and maybe pipeline to embolise this aneurysm. And the second case also is aneurysm in dissecting aneurysm in cavernous segment of the internal carotid artery. So we can also use the pipeline or tube range, such as the flow diver, to treat this aneurysm, and just with plus some coin to have this aneurysm block. So how we survive in this trial, and how a young cerebral vascular surgeon to survive in this condition. Just like the first we can use we just categorize all aneurysm into two groups. The first group is the BOT tolerant aneurysm. For this aneurysm, we just can clip them. Maybe blocker aneurysm itself, just blocker the parent artery itself. So the first case is a 34-year-old woman with the symptom aneurysm in our medical institution. So we after admission, we just perform the BOT test and find this aneurysm is the aneurysm. The patient can tolerate the BOT test. So we can see here. This aneurysm, if we block his right internal ICA and the left ACA can compensate the right MCA region. So we can just block the parent artery. here. So you can see here, we can just find the blood cycle is ophthalmic artery, and in the afterline of the aneurysm, we can see one branch from here. So here during the surgery, we can dissect the aneurysm. And we find the aneurysm ruptured. Here. And then we just then block the aneurysm. So after surgery, we recheck the DSA examination, and we find the aneurysm is blocked, and the right ICA is also blocked. However, the right MCA range is compensated by the left MCA and ACA. So the patient is asymptomatic after surgery. And this also left MCA artery was clipped by shape. Yes, is the first is a preoperative the DSA examination. We can see two branches from the aneurysm. And during surgery, we just use the two clip to shape this aneurysm and protect the two branches of this from this aneurysm. So we just present how we treat patient with BOT tolerant, and if we meet a BOT intolerant patient, how to treat this patient. So in this condition, our experience is more important, because if we treat this aneurysm, we can use the bypass technique to treat this aneurysm, which this technique is cannot be completed by interventional treatment. So here we just want to present our experience for treatment patient with BOT intolerant and aneurysm cannot clip directly. The first case is a 55-year-old woman with giant aneurysm. This patient was to our institution because sudden diplopia for 2 years. And here we can see a giant aneurysm in the right in the ophthalmic artery. So in our strategy, we just want to do STA to MCA bypass to insulate this aneurysm and protect the flow of the blood flow of MCA range. Here, we suit the STA. And we isolate the STA. And then we perform the Perturin approach territory and dissect the MCA. Then we perform the STA to MCA bypass firstly. Here we just Yes, after sta-mca bypass, we find the bypass is work. And then we clip the aneurysm. Here is a post-operative the CTA examination. Show the sta to MTA's work very well, and the patient was no symptom. And the second case is a 15-year-old man present a middle cerebral artery MCA aneurysm. And the aneurysm, we find a branch from the aneurysm body. So we just perform sta to MCA bypass and isolate the aneurysm. Here, we suit the M3. And perform the bypass. And then we prove this work. And then clip the aneurysm. The case 3 is a 14-year-old woman come to our hospital before the intermittent headache for 1 month. And here we can find the aneurysm in MCA. And here 2 branches from the body of aneurysm. So we complete the preoperative examination and find that the perfusion of brain is okay. However, the aneurysm may be a maybe a loss of thrombosis in this aneurysm body. So here we find that the aneurysm may be a dissecting aneurysm, and this aneurysm involving the whole M2 vessels. So it's very difficult to just shape or just clip this aneurysm. We have to protect the 2 branches of this from this aneurysm. So here, our strategy is clip this aneurysm, and then we can make a side-by-side bypass to protect the flow, the blood flow of the M2 vessels. Here, we have a demo to present our strategy. For this aneurysm, we just block the distal vessel. Then we performed the sta to MCA bypass, and then performed a side-by-side bypass of M2 vessels. And prove their work and isolate the aneurysm. Here is the actual condition, is the actual process of our operation. We find M2 vessels. and then suture the aneurysm. Here, we explore the aneurysm and find the two branch of M2 vessels from aneurysm body. Yes, this dissected the M2 vessels. And then block the aneurysm and M2 vessels. Here, we first perform the sta-mca bypass. We find it work, and then yes, here we block the aneurysm. Use the intraoperative DSA, and we find it work. And then we performed the side-by-side bypass of M2 vessels. And use ICG examination. We find ICG examination. We proved the bypass is work. And then we find the aneurysm is too large, and we cut this aneurysm and remove the thrombosis of aneurysm. So the first case is a 49 years old woman present find aneurysm with a sudden head for 12 hours. So the aneurysm is ruptured before. Here we just clip this aneurysm at the first administration. And after surgery, we check the DSA examination and find the aneurysm is blocked. However, after 1 year after surgery, we find that this aneurysm is recurrent. Use the DSA examination, we consider this the aneurysm is recurrent before the clip is removed. Yes, it's moving. So the clip is moving, and a new aneurysm recurrent from the neck of the original aneurysm. Is our operation. During operation, we just detect the aneurysm. Detect this aneurysm. And performed a side-by-side bypass. And then we find the previous clips. And then dissecting the aneurysm and find the side-by-side bypass is work. we also use the intraoperative DSA to prove the side-by-side bypass is work. And then we further dissect this aneurysm. And then we just remove the previous, keep the previous clip. And remove the aneurysm. However, we find that this aneurysm is clip incomplete, and then we readjust our clip, and the aneurysm is also incomplete clipped. So we just remove the aneurysm and suture the artery. Yes, it is suture artery. Intra-ICG test and DSA examination show the M2 vessel is protected well. So here we use the strategy, the side-by-side bypass to protect M2 vessel and keep M1 vessels to protect the blood flow of and the perfusion of M2 vessel, MCA region. And the sixth case is 15-3-year-old man to our department because dizziness for 5 months. And here we find a giant aneurysm in MCA. And here preoperative examination shows the brain perfusion is okay. And our preoperative DSA examination show a large aneurysm in MCA and 2 branches from the body of MCA. Here, a very important history of this patient. This patient have the atrial maxima. So preoperative examination shows the aneurysm, just a giant aneurysm, maybe dissecting, and no thrombosis in this aneurysm, and the perfusion is okay. Here, we just have a demo to present our strategy to treat this aneurysm. In this strategy, we use the lateral, contralateral, the STA to the aneurysm side. And we perform STA to MCA bypass first to provide blood flow, and then remove the M2 vessel from this aneurysm. And bypass the isolate STA to ME vessel. And prove this work. And then bypass the isolate STA to the another M2 vessel. Here we dissect the cilium and then dissect the aneurysm. This is the M2 vessel from aneurysm and another M2 vessel from aneurysm. Here, we first perform a sta-mca bypass. And this is isolate sta. This is M2 vessel from aneurysm, and we cut this aneurysm, this vessel, and suit M2 vessel and isolate sta. And then prove its work. Then we cut isolate another M2 vessel. And perform a head side bypass of ME vessel and isolate sta. And prove its work. And then we perform a head to side bypass of another M2 vessel. And prove its work. Use ICG examination. So after surgery, we use the DSA examination, find the MC is where. And the ST provides a blood flow to MC region. Post-operative, we find that the perfusion of brain is very rare, and no large ischemic range was found. The next case is a 38-year-old woman. To our administration because of headache. And we find preoperative DSA examination find aneurysm in ACA and 2 branch from this aneurysm. So during surgery, we first dissecting the aneurysm. And find the thrombosis in this aneurysm, and the aneurysm may be in a dissection. So we just clip the aneurysm, find the blood flow. The blood flow cannot preserve after clip. So So we just perform. We just suit the remained ACA vessel. And then do head to side bypass of another AC vessel. Here we just a demo to present our strategy. For this aneurysm, we use the longitude approach. And dissecting this aneurysm. Firstly, we just clip the aneurysm and find the blood flow cannot be preserved. And we suit the remained ACA and perform a tip and side bypass of another ACA. And our intraoperative DCA examination show the aneurysm is missed and the blood flow of AC is very rare. So this is here we just suit the remained ACA. Use ICG examination, prove this work. And then we find the blood flow of the another AC is not very rare and perform a tip side bypass to provide additional blood flow to another ACA vessel. And use ICG, find its work. So this is the intraoperative DCA examination. So the aneurysm is missed, and the ACA range have a rare blood flow. And the patient, the patient recovery very well. His low limb is maybe weak. However, after 6 months after surgery, the patient can walk itself. And the last case is the PICA bypass, occipital artery PICA bypass technique to treat the PICA aneurysm. Here, we just use the occipital artery to PICA bypass to preserve the distal blood flow of the PICA, and then embolism the proximal of the aneurysm, and then the aneurysm is dismissed in our in post-operative DCA examination. So it's also a demo to show how we perform this surgery. Here, we dissect the aneurysm. and use occipital artery to sta-mca bypass. And then we clip the aneurysm and use endovascular technique to place a coin to block this aneurysm. And the aneurysm is missed, it's blocked. So the distal sta-mca is supplied by occipital artery. This is our operation. Here is to dissect the occipital artery. Here is our dissected aneurysm and expose and free the sta-mca. Then we perform the occipital artery to sta-mca bypass. And ICG approved its work. Then we use the endovascular treatment technique to block this aneurysm. Post-operative DSA examination showed the aneurysm is missed and the sta-mca blood flow is preserved. Yes, aneurysm is dismissed. So during the interventional preoperative context, surgical treatment strategy for aneurysm, special for giant aneurysm, is also work. So young cerebral surgeons need to handle the bypass technique to treat some complex or giant aneurysm. Many aneurysms cannot be just be clip or just be embolism by endovascular technique. So it's very necessary to have the idea of the hybrid in the surgery and choose the best and the safety treatment strategy to treat this aneurysm. Thank you for your attention. It's our experience. Hope.
Congratulations for the presentation. Impeccable, very complete. The way that was showed the techniques is outstanding. I must say that he gave the same message that I talked before the lecture. Then I agree completely with what he said. Professor, we have a couple of questions that I will give to you, and you can answer. The first question is, thank you very much for your lecture. I would like to whether the internal maxillary artery is reliable as a donor for high flow bypass. What do you think about the IMAX?
Yes, yes. I'm sorry. I have to explain. The first case is the high flow bypass. Is not just a low flow bypass. Okay. Internal maxillary artery is less used in high flow bypass. the operation is very complex. So we usually use the STA to perform the bypass.
The second question is how long take the occipital artery pica bypass procedure? Just the bypass after the clip. I think he's asking how long you take to do the suture.
Just 30 minutes.
30 minutes, okay. I think that the question is in the way that the occipital artery dissection is a little bit long. But you know, the thing is, we must don't care about the time you need to dissect occipital artery. The important thing is the suture, and the loop of the pica, the caudal loop of the pica is very comfortable to do the bypass. Distal is normally have a good diameter. The pica and the occipital artery is most of the time is big, 2 millimeter maybe. And then I think I like a lot the occipital pica bypass more than the pica. Okay, because this I said to the young guys is you must start doing the occipital pica because for two reasons. The first reason is it's good for ischemia of the posterior circulation. A second reason is if you do a pica and the something did wrong, you lost 2 picas. And then for me, it's very important if you're not going to do a side-to-side pica, you need to have experience because that bypass is a third generation bypass. You need to be first a master in sta-mca, occipital pica. After that, second generation, the radial graft, bypass, high flow. And at the end, you do this side-to-side or other variation of third generation bypass. But the occipital pica is a very good bypass. And the other question is a technical question about what is the software you use for the demo in the computer.
Yes, the first question. This recurrent after embolism. So the loop is dissected, is placed lower, and so we cannot use the loop to pica bypass. So we just use the occipital artery to bypass to pica. The first question, and the second question, we also perform the pica to pica bypass. However, in this case, we do not perform the pica to pica because because the lateral, the contralateral, the pica is also affected by preoperative embolism. So if we use the pica to pica, we worried about the contralateral pica blood flow of the contralateral pica. So we just perform the occipital to pica bypass to preserve the blood flow. And we have this video that use the Maya software. It's a very interesting software. Yeah.
Okay, thank you very much. Any more questions? Prof. Pota, would you like to ask something?
Thank you for your beautiful presentation. I congratulate you. Can I ask the balloon test occlusion is essential for treat the giant internal carotid artery? Because I think the balloon test occlusion is not reliable. So in my opinion, we have to do a bypass for all cases. How do you think?
I think both examination is a very important examination for giant aneurysm. Use this both examination, we can know the composition of whole of Willis circle or of control MCA range to lateral MCA range. In this, for all of our patients, we just performed enhanced BOT examination. So in this enhanced BOT examination, we just completely block the ICA and to know how this work, how composition of control of one side MCA to another side MCA region. And after the surgery, this patient is all okay. So we just think both is very important.
Right. Thank you. Thank you very much. One question I would like to put across to you is after bypass, what is the anticoagulation policy in your place? Did you give heparin post-operatively, and when will you convert it to antiplatelets like Pasugrel or Plavix, and how long?
After surgery, we used give patient aspirin as the anticoagulate treat therapy and no heparin for this patient. We just have this. We just tell this patient to have 1 to 2 months aspirin treatment, and then we will then recheck the vessel of this aneurysm and then decide how long to continue or just stop. Okay.
Yes, and I would like to thank you for this great lecture showing a quick bypass technique for the difficult aneurysm. I would like to ask that, like, I saw that you also performed the bypass surgery during the rupture aneurysm cases. So I would like to ask about, like, because like for the sometimes when we for the rupture cases, we will raise the blood pressure in order to avoid the vasospasm during the phase of vasospasm for the subhumeral hemorrhage. So usually, would there be any concerns, especially if there is after the bypass and then you raise the blood pressure, say to up to like a 160 and 180, maybe at the day 5 to day 7 of the subarachnoid hemorrhage? How would you manage the blood pressure?
Thank you for question. And the first, all the case in our point in our lecture is unruptured aneurysm to our medical center. So maybe the aneurysm maybe have some little or minor bleeding before, and to our hospital, this aneurysm is unruptured. So if you treat ruptured aneurysm use bypass technique, you maybe the brain is edema, and the intracranial pressure is very high, and it's very difficult to perform the bypass technique. So we do not perform the bypass technique for patient with ruptured aneurysm. Yes. And after surgery, we just control the blood pressure. The blood pressure is very important after surgery. So we also will have a blood pressure controlling management after surgery. Maybe just more than 10 micromillimeter to their usually blood pressure. Yes.
Thank you.
We may do not low flow the bypass during emergency surgery. If we have to do, we just do high flow bypass surgery in emergent condition. Yes.
Thank you very much. So I think we had a wonderful lecture followed by a great discussion. We can move on to our honorable chair, Professor Jorge Mura, for his concluding remarks.
Yes.
Thank you.
I want to thank to everybody, Professor Xunye, really nice presentation, complete, very nice conceptual presentation, and I want to finish just saying that when we start today talking about microsurgery, these two lectures that we saw today for Felix and from the Professor Xunye are showing us that the microsurgery is still alive and evolving, and we have a nice imaging, nice instrumentation, and now fortunately with the quality of the videos and the other things that we have, we can show that the microsurgery is safe, is good for the patients, and now the young neurosurgeons need to keep going and keep learning these techniques. Thank you to everybody to be here today.
Well, thank you very much. I think we can close this officially now. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, I would like to thank both speakers of today, Dr. Felix Gore and Professor Yesun and his colleague, as well as the chairs, Professor Nakaota and Professor Jorge Mura, for the time and support for the ACNS webinars. Very special thanks to Professor Shubin for broadcasting this webinar on the WeChat channel, and special thanks to my co-host Dr. Libun Singh and also Dr. Ben for joining me today. So until we all meet online tomorrow, it is bye-bye from all of us. Thank you very much for joining.